Good evening, folks. Welcome to SUPERPoints. I hope you are enjoying these episodes as you prepare for your examination. Today, we will continue pathology. We are going to see some very high-yield material. Listen to every sentence carefully because these questions and answers are loaded with only high-yield material. Okay? So please listen to carefully everything I say. A 42-year-old woman presents to her primary care physician with a 6-month history of episodic headaches, palpitations, excessive sweating. She describes these episodes as occurring suddenly, lasting 10 to 20 minutes, and resolving spontaneously. She also reports occasional feelings of anxiety during these episodes, but denies weight loss, chest pain, and syncope. Her medical history is significant for hypertension diagnosed 1 year ago, which has been difficult to control despite treatment with 2 antihypertensive medications. She has no family history of endocrine disorders or malignancy. On physical examination, her blood pressure is 170 by 105, heart rate 92. She appears diaphoretic, no abdominal masses are palpable, and the remainder of examination is unremarkable. Laboratory studies show plasma free metanephrine is elevated, 24-hour urinary catecholamines elevated, serum electrolytes normal, renal function normal. An abdominal CT scan reveals a 4 centimeter well-circumscribed homogeneous mass in the left adrenal gland with a Hounsfield unit density of 25, suggestive of a non-calcified lesion. No evidence of a local invasion or metastasis is noted. A subsequent meta-iodobenzyl guanidine MIBG scan shows increased uptake in the region of the adrenal mass. Which of the following histopathological findings is most consistent with this patient's condition? So please take your time and choose your best answer. So the best answer here is A. Why? Let us say nets of polygonal cells with granular cytoplasm, salt and pepper chromatin surrounded by sustentacular cells. So what is the topic? Always think about topic. That will make your life a lot easy. So this is the topic of pheochromocytoma, adrenal medullary tumor with gel-balloon histology. Pheochromocytoma is a catecholamine secreting tumor arising from chromaffin cells of the adrenal medulla, which are derived from neural crest cells. These tumors produce excess epinephrine and norepinephrine, leading to episodic sympathetic overactivity. Clinically, pheochromocytoma presents with a classic triad of episodic headaches, palpitations, and diaphoresis. So, basically what is happening in pheochromocytoma is a chromaffin cell tumor of the adrenal medulla with associated excess production of catecholamines. Right? And if you see, you will see small distinct nets of chief cells separated by a prominent delicate fibrovascular stroma, Zellballen pattern. So that's an important point. The cells here are arranged in Zellballen pattern. And there are sustentacular cells. There is abundant fine granular red-purple cytoplasm. There are round oval nuclei with prominent nucleoli. So pheochromocytoma arises from the adrenal gland. Okay, that's very important understanding. It is coming from adrenal medulla. You need to know that. Do not get confused from adrenal medulla, adrenal cortex. It is coming from adrenal medulla and it is producing catecholamines. So think about your shower. You are bathed in all catecholamines. There is epinephrine falling on you, and this causes anxiety attacks. There is norepinephrine falling upon you. It causes severe headaches, profuse sweating, chest pain, shortness of breath, palpitations. And if there are a lot of palpitations, you can have heart attacks. And hepatic encephalopathy, hypertension, kidney dysfunction, abdominal pain. And finally, there is vanillin mandelic acid excreted in the urine. That's a very interesting and important question, all right? You may get a question like that. What is excreted in the urine? It is vanillin mandelic acid. So there is Raynaud syndrome, cyanosis, flushing, eczema. So imagine a lot of catecholamines are showering upon you. That is pheochromocytoma. So it is often associated with paroxysmal or resistant hypertension, and diagnosis is confirmed by elevated plasma-free metanephrines or urinary catecholamines. Imaging typically shows a well-circumscribed adrenal mass, and functional imaging such as MIBG scanning demonstrates increased uptake due to catecholamine production. So histology, you can get a question on histology. So histologically, as I told you earlier, the defining feature is the Zellballen pattern, nest of polygonal chromaffin cells with granular cytoplasm and salt and pepper chromatin surrounded by sustentacular cells with a rich vascular stroma. Pheothroes zebra ball sprinkled with salt and supported by sustainers. Pheo stands for pheochromocytoma, zebra ball, Zellballen pattern, salt and pepper chromatin, sustainers, sustentacular cells. Okay, so remember that mnemonic. Pheo throws a zebra ball sprinkled with salt and supported by sustainers. All right. So Pheo is for pheochromocytoma, zebra ball for Zellballen pattern, salt and pepper chromatin, sustainers for sustentacular cells. So this mnemonic helped me to remember all those important features. So why not incorrect answers? Why not B? B is lipid-laden cortical cells resembling normal adrenal cortex arranged in nets. This describes an adrenal cortical adenoma. All right. So it is saying about adrenal cortex. So this is not about adrenal cortex. This is adrenal medulla. These tumors arise from adrenal cortex and they produce cortisol, Cushing syndrome, or aldosterone-Conn syndrome. Histology shows clear lipid-rich cortical cells, not chromaffin cells, in a Zellballen pattern. They do not cause episodic catecholamine excess. Small round blue cells forming Homer-right rosettes. This describes neuroblastoma, a malignant tumor of primitive neural crest cells, most common in children. Histology shows small round blue cells and Homer-right rosettes. Although it may produce catecholamine metabolites, it occurs in pediatric patients and lacks Zellballen architecture. So Homer-right rosettes, you need to think about neuroblastoma. All right? Then sheets of pleomorphic giant cells with necrosis and capsular invasion. What is this? This is adenocortical carcinoma, a highly aggressive cortical tumor. Histology shows marked pleomorphism, necrosis, and invasive growth. These tumors often produce steroid hormones, not catecholamines, and do not show chromaffin nest cells. So the key distinction here is pheochromocytoma is a medullary tumor. That's important. It's a medullary tumor with a Zellballen pattern and catecholamine excess, whereas other options describe cortical or pediatric tumors with different histologic architectures and hormonal profiles. So what is the super formula here? Patient presents with paroxysmal hypertension, headache, palpitation, diaphoresis, and if you see neural crest origin, and if you see adrenal medulla tumor, if you see there is episodic catecholamine excess, if you see there is elevated plasma metanephrines, elevated urinary catecholamines, and if you see Zellballen pattern, sometimes they may not even tell you Zellballen. That's a clear giveaway. So they don't say Zellballen. They will just say nests of polygonal cells with salt and pepper chromatin. Then the answer is pheochromocytoma. The super point is pheochromocytoma is a retinal medullary tumor of chromaffin cells that causes episodic hypertension and shows the classic Zellballen pattern, nests of polygonal cells with salt and pepper chromatin surrounded by sustentacular cells. All right, folks, that is very important. All right, pheochromocytoma, very important. I can't stress that enough. So make sure you understand everything. It's pathogenesis, it's histology, it's diagnosis, it's management, everything. All right, that's a very interesting question. Next, let us see this one. A 41-year-old man presents with progressive headaches and decreased peripheral vision. MRI of the brain shows a cellular mass compressing optic chiasm. The lesion is surgically resected. Histologic examination demonstrates uniform cells, sheets of polygonal cells with a loss of normal acinar architecture. A special reticulin stain is applied. Which of the following findings would be most characteristic of this patient's lesion? All right. So we have like 4 options. So choose the best answer and we will discuss. So if you see, the best answer here is absence of reticulin network. All right, that is the best answer. Let us see why B is the best answer. Okay. First of all, what is it talking about? He is talking about pituitary adenoma. All right. In pituitary adenoma, you have histologic loss of reticulin framework. Pituitary adenomas are benign monoclonal neoplasms arising from the anterior pituitary, adenohypophysis. They commonly present either through mass effect or bitemporal hemianopsia from optic chiasm compression or hormonal hypersecretion, prolactin, GS, ACTH excess. Histologically, the key diagnostic feature that distinguishes a pituitary adenoma from normal pituitary tissue or diffuse hyperplasia is disruption of the normal reticulin fiber network. In the normal anterior pituitary, reticulin fibers form a delicate framework that divides endocrine cells into well-organized acini. In pituitary adenomas, this reticulin architecture is lost and the tumor cells grow in uniform solid sheets or cords, a defining microscopic landmark. This architectural loss, demonstrated by special reticulin staining, is central to pathologic diagnosis. So how do I remember this? All right, that's where supranemonic cell pass. All right, pituitary adenoma, pit loses its net. All right, remember that. Pituitary adenoma, pit loses its net. All right, so pit here is pituitary tumor, loss, and net reticulin network. So normal pituitary has a net. Normal pit has a net. Adenoma tears the net. Right? When the adenoma comes, it destroys this net. So you need to know this histopathology. So basically, this is a histopathology question. All right. So loss of reticulin framework, solid sheets of cells instead of acini. So now let us see incorrect answers. You will learn a lot. So don't just ignore these explanations. You will learn a lot from each incorrect answer. Now, first, preservation of reticulin framework. Well, that is what happens in the normal pituitary. So that is not the answer here. Normal pituitary, anterior pituitary tissue is organized into acini, separated by an intact reticulin fiber network. Diffuse pituitary hyperplasia also preserves this reticulin architecture. In contrast, pituitary adenomas disrupt and lose the reticulin framework, leading to sheets of uniform tumor cells. Therefore, preservation of reticulin argues against adenoma. Then papillary fronds with orphan Annie nuclei. All right, orphan Annie nuclei and optically clear nuclei with nuclear grooves and samoma bodies are characteristic of papillary thyroid carcinoma. So when I was in my residency, I did family medicine residency. In the second year, I saw this patient with papillary thyroid carcinoma. So that is why I remember this. And she has these characteristic features, samoma bodies and orphan Annie nuclei. So these features reflect thyroid follicular epithelial origin and are unrelated to pituitary tissue. A cellular mass with these findings would not represent a pituitary adenoma. Next, D, a rosette formation with small round blue cells. So hormone right rosettes, all right, we already told about that, all right, neuroblastoma, medulloblastoma, that's where we see. These tumors consist of primitive neuroectodermal cells and are typically pediatric neoplasms. Pituitary adenomas are composed of uniform endocrine cells and do not form rosettes. So we don't see rosettes in pituitary adenomas. So what is the super formula? Super formula is like you look at the keywords and you go to the diagnosis in a few seconds. All right, learn to read these super formulas. They are extremely useful, especially to rapidly revise in the exams last final weeks. So if you see a patient presenting with progressive headaches, decreased peripheral vision, so that's a great clue. The decreased peripheral vision, the bitemporal hemianopsia is happening. Optic chiasm is compressed. And the monoclonal anterior pituitary tumor, there is loss of reticulin framework. Solid sheets of uniform polygonal endocrinal cells. So what should you think? You should think about pituitary adenoma. All right, loss of that is the super point from what you learned from this entire question. What is the super point? Loss of reticulin framework is the defining histologic feature of pituitary adenomas, distinguishing them from normal pituitary hyperplasia. So this is the defining histologic feature. All right, folks, please remember that. Let's go to the next question. A 24-year-old man presents to the clinic with a 6-month history of progressive chronic fatigue, frequent easy bruising, persistent bone pain, primarily affecting the hips and femurs. He reports increasing difficulty with physical activities due to weakness and discomfort. The patient denies recent trauma, fever, or weight loss, but notes occasional abdominal discomfort and a sense of fullness. His medical history is unremarkable with no prior surgeries, chronic illness, or significant family history of genetic disorders. He is not taking any medications and denies recreational drug use or excessive alcohol consumption. On physical examination, the patient appears pale and has a slightly distended abdomen. Notable findings include massive splenomegaly. Alright, remember that there is a massive spleen. When they say there is a massive splenomegaly, he is giving you a clue. With the spleen palpable 8 centimeters below the left costal margin, hepatomegaly with the liver edge palpable 5 centimeters below the right costal margin. There are no palpable lymph nodes, and the skin shows no rashes or abnormal pigmentation. Musculoskeletal examination reveals tenderness and palpation of the proximal femurs bilaterally, but no joint deformities or swelling. Laboratory studies show a hemoglobin of 9.8 grams per deciliter, anemia, platelet count of 90,000 per microliter, thrombocytopenia, normal white blood cell count. Radiographs of the femur demonstrate a deformity characterized by widening of the distal femur with a flask-like appearance. Is giving you so many clues. Alright, that is like a femur is showing a flask-like appearance. A bone marrow biopsy is performed revealing large macrophages with abundant fibrillary cytoplasm that resembles wrinkled tissue paper on histological examination. There is no evidence of central nervous system involvement, as the patient has no neurological symptoms such as seizures, cognitive impairment, or motor deficits, and a neurological exam is normal. Which of the following best explains the underlying pathology in this patient's condition? All right, folks, there are 4 choices. Please choose the best answer. All right, all the clues are in the question stem, so it should be very easy. In fact, if you find, as I told you, if you look at the keywords, you don't even have to, this is a long story, you don't even have to go through the long story. If you look at those key features, you can easily find the diagnosis here. So the correct answer here is C. Why? Let us see what is going on here. So C is deficiency of glucocerebrosidase with accumulation of glucocerebroside in macrophages. So what is the topic? The topic is Gaucher disease type 1, lysosomal storage disorder of macrophages. So Gaucher disease is the most common lysosomal storage disorder, as is inherited in an autosomal recessive pattern. It results from a deficiency of the enzyme glucocerebrosidase, leading to accumulation of glucocerebroside within macrophages of the reticuloendothelial system. The accumulated lipid transforms macrophages into characteristic Gaucher cells, which exhibit abundant fibrillary cytoplasm with a wrinkled tissue paper appearance. So they don't tell you there's a Gaucher cells, all right? If they tell you Gaucher cells, you would immediately say, oh, this is Gaucher disease, all right? So they don't tell you that. They rather give you that description. They may not even tell you wrinkled tissue paper appearance, because even that is a giveaway. They will usually say, from what when I took the USMLE and the NEET exams, that is what I found out. They don't give away these things that quickly. Yes, some questions they give you. In some questions they go for abundant fibrillary cytoplasm. They actually give that histological features. All right. So if you see a normal lysosome, you see glucocerebroside changing into ceramide and glucose. All right. So glucocerebrosidase is changing glucocerebroside into ceramide and glucose. So normal lysosome is here with the functional glucocerebrosidase breaking down glucocerebroside into glucose and ceramide. So Gaucher disease is caused by a deficiency of glucocerebrosidase leading to accumulation of glucocerebroside. All right. So what is happening? Glucocerebroside is accumulating. All right. This enzyme glucocerebrosidase is not there. So ceramide is not forming. Glucose is not forming. But glucocerebroside is accumulating. And as it accumulates, enlarged macrophages with wrinkled tissue cytoplasm. So you see, these are like, if you see here, it's almost like looking from the top, like when you have a tissue paper roll and it got wet. And if you look from the top, that is how this is looking here. It is like this wrinkled tissue paper appearance. So remember that. What is happening here? So there is fatigue, there is easy bruising, there is splenomegaly. All right, the spleen becomes very large here. There is hepatomegaly, the liver becomes very big. There is thrombocytopenia, the platelets are low. There is anemia, hemoglobin is low. There is bone pain and osteopenia. And Erlenmeyer flask deformity, all right, flayed distal end, all right, we have seen that. What did he say in the question? We have seen here, all right. What did it say? Radiographs of the femur demonstrate a deformity characterized by widening of the distal femur with a flask-like appearance. Distal femur with a flask-like appearance. That is a very key radiographic finding in Gaucher disease. So remember that. So that is what we are seeing here. This distal femur, there is Erlenmeyer flask deformity is happening. So the super point is type 1 Gaucher disease is caused by glucocerebrosidase deficiency leading to accumulation of glucocerebroside in macrophages with hepatosplenomegaly, bone marrow infiltration, Erlenmeyer flask deformity, and no CNS involvement. Microscopic morphology shows tissue paper cells, lipid-laden macrophages with wrinkled cytoplasm. In the most common form, type 1 neuronopathic Gaucher disease, lipid-laden macrophages infiltrate the spleen, liver, and bone marrow, producing massive hepatosplenomegaly, cytopenias, bone pain, skeletal deformities, Erlenmeyer flask deformity, absence of central nervous system involvement. All right? Recognition of the clinical trait, hepatosplenomegaly, cytopenias, and bone abnormalities combined with classic histopathological appearance is essential for diagnosis. So how do I remember? I always go by mnemonics. All right? That is how, because 6 months from now, when I think about it, many times is mnemonic that helps me. Gaucher is glucocerebrosidase, growing spleen, glass flask, and crumbled tissue paper. So remember that one thing: Gaucher, glucocerebrosidase, growing spleen, glass flask, and crumpled tissue paper. So glucocerebrosidase is for enzyme deficiency, growing spleen is for massive splenomegaly, glass flask is for Erlenmeyer deformity, crumpled tissue paper is for classic Gaucher cells, pathognomonic morphology. What about incorrect answers? If you see A, deficiency of alpha-glucogalactosidase A with accumulation of globotriazosyl ceramide in vascular endothelium, Fabry disease. All right, this is Fabry disease. Is an X-linked lysosomal storage disorder caused by accumulation of globotriazosyl ceramide in vascular endothelium. Patients present with angiokeratomas, acroparesthesias, hypohidrosis, and progressive renal and cardiac disease, bone pain with Erlenmeyer flask deformity, and massive hepatosplenomegaly are not characteristic findings. Next, deficiency of hexosaminidase A with accumulation of GM2 ganglioside in neurons. Tay-Sachs results in GM2 ganglioside accumulation in neurons, leading to progressive neurodegeneration and developmental regression and a cherry red macula. A key distinguishing feature is the absence of hepatosplenomegaly. This patient instead has massive splenomegaly. All right? In Tay-Sachs disease, there is no hepatosplenomegaly. This patient has a big spleen and big liver, so this is not Tay-Sachs disease. Then D, deficiency of sphingomyelinase with accumulation of sphingomyelin in reticuloendothelial cells. This is Niemann-Pick disease. Okay, Niemann-Pick disease causes sphingomyelin accumulation in macrophages and neurons, producing hepatosplenomegaly, neurodegeneration, foam cells, and often a cherry red macula. Prominent neurological involvement distinguishes it from type 1 Gaucher disease. All right? In type 1 Gaucher disease, you don't have CNS manifestations. So what is this super formula? Super formula is just, you see, these key concepts and arrive at the answer. For example, if a patient has frequent easy bruising, and if they tell you it is autosomal recessive, there's glucocerebrosidase deficiency, I mean, that's enough to say it is Gaucher's disease. And if they tell you there is glucocerebroside accumulation in macrophages, there is wrinkled tissue paper cytoplasm, hepatosplenomegaly. If they tell you there is Erlenmeyer flask deformity, there is no CNS involvement, so then it is Gaucher disease, type 1. So super point here is type 1 Gaucher disease is caused by glucocerebrosidase deficiency, leading to accumulation of glucocerebroside in macrophages, wrinkled tissue paper cells, resulting in massive hepatosplenomegaly, cytopenias, and Erlenmeyer flask deformity without CNS involvement. All right, folks. So very, very, very important. Lysosomal storage diseases are extremely important. So make sure you know them well. All right, next question. A 42-year-old woman presents with progressive fatigue, weight loss, and diffuse hyperpigmentation of her skin and oral mucosa. Blood pressure is 88 by 60 mmHg. Laboratory studies reveal hyponatremia, hyperkalemia, and low cortisol levels. ACTH is markedly elevated. Adrenal biopsy shows a dense lymphocytic infiltrate with cortical atrophy. All right. So which of the following best explains the underlying pathology in this patient's condition? All right, folks. Choose one best answer, and we will discuss this question. So the best answer here is A, autoimmune destruction of the adrenal cortex. Basically, what is he talking about? What is the topic? The topic is Addison's disease, right? Addison's disease, you have fatigue, weight loss, hyperpigmentation. That is a very good clue. There is hypotension. There is hyponatremia, hyperkalemia, low cortisol level. And the ACTH is elevated. And there is dense lymphocytic infiltrate with cortical atrophy. So those clues are enough to say that's Addison's disease. But now the next step, he's testing you two things. First, do you know the diagnosis? Okay, you know the diagnosis. Then tell me, what is the pathogenesis of this disease? So this is like you have to make those two steps. All right, first arrive at the diagnosis, and then from diagnosis, you need to tell them what is the pathogenesis. The pathogenesis here is autoimmune destruction of the adrenal cortex. Let us say, so primary adrenal insufficiency, Addison's disease, is autoimmune adrenalitis. It is caused by destruction of the adrenal cortex, leading to deficient production of glucocorticoids, mineralocorticoids, and adrenal androgens. In developed countries, the most common cause is autoimmune adrenalitis, characterized pathologically by dense lymphocytic infiltration and progressive cortical atrophy. As adrenal hormone production declines, patients develop hypertension, hyponatremia, hyperkalemia, fatigue, and weight loss. Because cortisol level falls, negative feedback to the pituitary is lost, resulting in markedly elevated ACTH. Increased ACTH stimulates melanocyte receptors, producing characteristic diffuse hyperpigmentation of the skin and mucous membranes seen in primary adrenal insufficiency. So Addison's disease, you should know everything. If you don't know about this, don't even go to your exam because you will fail. Because this is very, very, very important. So what is happening in Addison's disease? There is autoimmune destruction of the adrenal gland is the most common cause. Unless the adrenal gland is destroyed. Now, it would be a very good habit if you know what is happening what, because this can be confusing, quite frankly. So if you see adrenal cortex, all right, and adrenal medulla, right, what is happening in adrenal medulla? So you can think about hypofunction and hyperfunction. In hyperfunction, we have diseases like hyperplasia, ganglioneuroma, neuroblastoma, and pheochromocytoma. We already discussed it. It comes in adrenal medulla, pheochromocytoma. What about hypofunction? Ischemia, hemorrhage, shock. And then cortex, there is hyperfunction, hypofunction. So in hyperfunction, you have primary aldosteronism, Cushing syndrome, excess ACTH, hyperandrogenism. In hypofunction, you have ischemia, shock, congenital adrenal hyperplasia, that is 21-hydroxylase deficiency, which is extremely important, and we will discuss also later. And then we have Edison's disease. So in adrenal cortex, this is being destroyed, okay? So adrenal medulla is fine, all right? This cortex is destroyed. So these T lymphocytes, CD4 T cells can release cytokines and chemokines that attract other immune cells such as CD8 T cells and macrophages to the adrenal cortex. Activation of CD8 cells, CD8 plus cytotoxic lymphocytes. These CD8 cells activated by CD4 T cells can directly attack and destroy adrenal cells that produce cortisol and aldosterone. So plasma cells, as you know, they produce autoantibodies directed against cortical antigens. Autoantibodies go after 21-hydroxylase. They go after 17-hydroxylase. They go after side chain cleavage. So these autoantibodies are destroying adrenal cortex. All right, folks, that is the pathophysiology. Remember that, all right? Recognition of the triad, low cortisol. Because cortisol is down, ACTH is going up. And lymphocytic cortisol destruction is essential for diagnosing autoimmune Addison disease. This patient has low cortisol, high ACTH, skin hyperpigmentation, hypotension, and electrolyte disturbances. Biopsy shows lymphocytic infiltrate with cortical atrophy, consistent with autoimmune adrenolitis, the leading cause of Addison disease. So, what is the supermnemonic? The mnemonic is addition is add dark skin and salt loss. Remember like that. Addison, add dark skin and salt loss. There is hyperpigmentation. Why? Cortisol is low. ACTH is high. So ACTH, when it goes up, it is also increasing melanocortin. That's why the melanin is increasing and the patients have hyperpigmentation. So AD stands for adrenal cortex destroyed, dark skin for hyperpigmentation, increased ACTH leads to increased MSH effects, salt loss happens, aldosterone deficiency, hyponatremia, hyperkalemia, low BP coming, low cortisol, fatigue, weight loss happening. All right, one other mnemonic I found extremely important and is primary versus secondary adrenal insufficiency. In primary adrenal insufficiency, pigment and potassium problem. All right, so primary adrenal insufficiency is pigment and potassium problem, whereas in secondary, there is no pigment, no potassium problem. So you will definitely get confused. What is the difference between primary and secondary? Remember this, in primary, there is pigment and potassium problem. See, there is hyperpigmentation and there is hypokalemia. Whereas in secondary, there is no pigment problem, there is no hyperpigmentation, and there is no potassium problem, there is no hypokalemia. So remember that mnemonic, folks. I will guarantee that you will appreciate my advice. So now let us say incorrect answers. B, pituitary corticotroph adenoma Cushing disease. A corticotroph adenoma produces excess ACTH, resulting in bilateral adrenocortical hyperplasia and elevated cortisol levels. Patients present with features of hypercortisolism such as central obesity, hypertension, and glucose intolerance, purple striae. So, this is Cushing's disease, all right? In Cushing, this patient has low cortisol, hypertension, adrenal cortical atrophy, which are consistent with Cushing's disease, all right? Then adrenal cortical adenoma with cortisol overproduction. And adrenal adenoma causes ACTH-independent Cushing syndrome with elevated cortisol and suppressed ACTH. The contralateral adrenal gland becomes atrophic due to ACTH suppression. Clinically, patients have signs of cortisol excess rather than adrenal insufficiency. This patient has high ACTH and low cortisol, excluding this diagnosis. Small cell carcinoma producing ectopic ACTH secretion leads to markedly elevated cortisol and bilateral adrenal hyperplasia. Patients develop severe hypercortisolism with hypertension and metabolic alcoholism. Although ACTH may be high, cortisol levels are elevated, not low. The hypertension, hyperkalemia, and hyponatremia seen here indicate primary adrenal failure, not ectopic ACTH production. So, SOPR formula. How can you go to the diagnosis in a few seconds? So, if you see a patient with fatigue, hyperpigmentation, autoimmune adrenal cortex destruction, lymphocytic infiltration, low cortisol, low aldosterone, high ACTH, hyponatremia, hyperkalemia, hypertension, then the answer is primary adrenal insufficiency or Addison's disease. All right, folks. So that's very important SUPER formula. Then SUPERPoint is Cushing syndrome results from excess cortisol due to adrenal adenoma, carcinoma, hyperplasia, ectopic ACTH with Addison disease is most often due to autoimmune destruction of the adrenal cortex causing lymphocytic infiltration, cortical atrophy, low cortisol, and high ACTH with hyperpigmentation. So remember, Addison's disease is very, very important. A lot of people have. John F. Kennedy had this disease, and those days there was not much understanding, but he was taking those cortisol injections regularly and he was fine. But you would see that hyperpigmentation under his neck. So John F. Kennedy unfortunately suffered from this disease. All right, folks. Next, let us go to the next question. A 28-year-old man is evaluated after his sister was recently diagnosed with medullary thyroid carcinoma. His family history is notable for multiple relatives with thyroid cancer and adrenal tumors. Genetic testing is performed to identify the underlying mutation responsible for this familial syndrome. Which of the following mutations is most likely present in this patient? All right, folks, we have like 4 options. Please answer this question, extremely important question. You will definitely get 1 question in your examination. This is that important. So we are going to discuss that. Please choose the best answer. So here the best answer is B. So what is this? Whenever they say there is a medullary thyroid cancer and multiple relatives, all right, have thyroid and adrenal tumors, you need to think about men, all right, men syndromes. Men 1, men 2A, men 2B, those things. Whenever they say multiple relatives, it's always, that is the problem. Now, again, the same thing. First, you need to find out the diagnosis, and then what is the pathogenesis. All right. The diagnosis here is men. What about men? What about the pathogenesis? Okay, we will see those things. So, first of all, they're talking about multiple endocrine neoplasia type 2, RET proto-oncogene mutation. So, multiple endocrine neoplasia type 2A also known as sickle syndrome, is an autosomal dominant hereditary cancer syndrome caused by a gain-of-function mutation in the RET proto-oncogene on chromosome 10q11.2. RET encodes a receptor tyrosine kinase, and constitutive activation of this receptor leads to uncontrolled cellular proliferation in neural crest-derived tissues. MEN2A is classically characterized by the triad of medullary thyroid carcinoma arising from calcitonin-producing parafollicular cells, pheochromocytoma, catecholamine-secreting tumor of adrenal medulla, parathyroid hyperplasia causing primary hyperparathyroidism. Because medullary thyroid carcinoma is often the earliest and most penetrant manifestation, genetic testing for RET mutations is critical in at-risk family members, allowing for prophylactic thyroidectomy and prevention of advanced disease. Recognition of RET gain-of-function mutations distinguishes MEN2 syndromes from MEN1, which results from tumor suppressor gene loss. All right, folks, I saw one patient in New York when I was doing my residency there. I saw one patient with this syndrome, and it's very interesting, and you need to know, because every exam has these questions. So first of all, the MEN syndromes are confusing. All right, so you need to find out a way to remember them. All right, so MEN1 and MEN1, MEN2A, and 2B. Go in an order and remember this diagram. It's extremely important. In MEN1, you have pituitary adenoma, parathyroid hyperplasia, and pancreatic tumors. Okay, so in MEN2A, go a little bit down. So they have parathyroid hyperplasia. All right, just like MEN1. And they also have medullary thyroid carcinoma. They have pheochromocytoma. All right, that is MEN2A. And then MEN2B, again, go a little bit down. That means like you still have medullary thyroid carcinoma. You still have pheochromocytoma, but two more things added. That is mucosal neuromas and morphonoid body habitus. So if you want some mnemonics, in MEN1 you have 3 P's. All right, there is pituitary adenoma, there is parathyroid hyperplasia, there is pancreatic tumors. In MEN2A, you have 2 P's and 1 M. All right, and in MEN2B, you have 3 M's and 1 P. All right, so in MEN1, you have tumor suppressor gene off. All right, that is the pathogenesis of MEN1. The tumor suppressor gene, which controls these cancers, it has been turned off. Whereas in MEN2A, you have a RET oncogene turned on. So in MEN2A and 2B, we have RET oncogene turned on. There, you have tumor suppressor gene turned off. All right, folks, you need to know that. The way I remember this is 2 men return on med-phi. All right, 2 men return on med-phi. What is this nonsense, you might ask? 2 men is for MEN2A and 2B. All right, so I remember like 2 men. All right, 2 men returned. So there in 2 men returned, there is RET. All right. So returned, there is RET oncogene turned on. All right, and then there is med-phi. Med-phi is for medullary thyroid carcinoma and pheochromocytoma. So 2A and 2B. In 2A, you have parathyroid. In 2B, you have neuromas and morphonoid. So super mnemonic here, MEN1 to MEN2A. In MEN1, tumor suppressor is off. In MEN2, the RET is on. All right, folks, remember that. And coming to incorrect answers, MEN1 tumor suppressor gene. MEN1 is caused by loss of function mutation of the menin tumor suppressor gene and leads to to the three P's: parathyroid adenomas, pituitary adenomas, pancreatic neuroendocrine tumors. Medullary thyroid carcinoma is not a feature of MEN1. The presence of familial MTC and pheochromocytoma instead indicates MEN2, which is caused by RET gain-of-function mutation. Then there is RB, retinoblastoma tumor suppressor gene. RB gene mutation disrupt G1S cell cycle checkpoint and are classically associated with retinoblastoma and osteosarcoma. Although RB is an important tumor suppressor gene, it is not linked to endocrine neoplasia syndromes or medullary thyroid carcinoma. Then TP53 tumor suppressor gene. TP53 mutations cause Life-Ramenis syndrome, which predisposes to a wide range of malignancies, including sarcomas, breast cancer, brain tumors, leukemias, and adenocortical carcinoma. However, it is not associated with medullary thyroid carcinoma or the MEN syndromes. So how do you go to the correct answer using a few key words? All right, that is SUPER formula. SUPER formula here is, if you see a patient presenting with a painless nodule in the front of the neck, hoarseness, dysphagia, they are saying it is autosomal dominant. When they say RET oncogene, all right, when they say RET proto-oncogene, you can forget about MEN1 and go to MEN2, all right? Then you have to figure out what is there. Then you have constitutive receptor tyrosine kinase activation, neural crest-derived tumor proliferation. If you see medullary thyroid carcinoma, pheochromocytoma, parathyroid hyperplasia, so they are talking about MEN2A, Sippel syndrome. Then SUPERPoints, MEN2A is caused by a gain-of-function mutation in the RET proto-oncogene leading to medullary thyroid carcinoma, pheochromocytoma, parathyroid hyperplasia, whereas MEN1 involves a tumor suppressor mutation, and MEN2B adds mucosal neuromas and morphinoid habitus. All right, folks. And in the remaining time, let us see one more question. A 16-year-old girl presents with primary amenorrhea. She is short in stature, has a broad chest with widely spaced nipples and a webbed neck. Blood pressure in the upper extremities is elevated, while pulses in the lower extremities are diminished. Laboratory studies reveal decreased estrogen, elevated FSH and LH. Pelvic ultrasound shows small streak-like gonads. Which of the following chromosomal abnormalities is most likely present in this patient? So, trisomy 21, 45X0, 47XXY, Robertsonian translocation. So, what is the best answer? This is a very easy question, so I will give you just a few seconds. You can get the right answer. All right, folks. So this is a very straightforward question, just like a few keywords. Like, for example, you can see these small streak gonads, webbed neck, widely spaced nipples, and this is a girl. All right. So what are they telling you? This is monosomy 45X0. This is Turner syndrome. All right. Extremely important. You will definitely get one question on this, and you should know. So, Turner syndrome is a chromosomal disorder caused by complete or partial monosomy of the 1X chromosome. It is only monosomy compatible with life and results in gonadal dysgenesis, leading to streak ovaries and primary ovarian failure. The absence of functional ovarian tissue produces low estrogen levels, which in turn causes elevated FSH and LH. Due to loss of negative feedback, clinically patients present with primary amenorrhea, short stature, webbed neck, and shielded chest with widely spaced nipples and lymphedema at birth. So you should have a good idea about what is happening in Turner syndrome. First of all, Turner syndrome is 45X0. So look at this chromosome. All right, there are 22. They're number 1, 2, 3, 4, 5, like that. There is 22, and in the 23rd here, that is like 22 double up. It is 44, right? So 45 is also there, but the next one is absent. You see the next one. So that is Turner syndrome. Turner syndrome is a chromosomal condition that affects biological females where one of the two X chromosomes is completely or partially missing. So there should be two X chromosomes in females, right? So in females, here you have only one X chromosome. That is the problem here. So you will see a broad webbed neck and a broad chest. You see kidney abnormalities. You will see hearing loss, low hairline, cardiac defects, increased risk of heart defects, particularly coarctation of the aorta. That's a very important question again. What kind of cardiac abnormalities you see in Turner's syndrome patients? Coarctation of the aorta is the answer. And then there is ovarian problems. Then there is lymphedema problems. Then there are autoimmune disorders. All right. So streak gonads, that is a very interesting and important question. So cardiovascular anomalies are common, particularly coarctation of the aorta and bicuspid aortic valve, explaining discrepancies in upper versus lower extremity pulses and blood pressure. Recognition of the combination of streak gonads, hypertrophic, hypergonadotropic hypogonadism, short stature, congenital heart disease is central to diagnosing Turner syndrome. So 45X0, Turner syndrome, you have a short stature, streak bowries, amenorrhea, webbed neck, and shield chest. There is cardiac coarctation of aorta. Then there is low estrogen, high FSH, LH due to gonadal failure. Pathology, ovaries replaced by fibrous streak tissue with no follicles. So how do you remember this? The super mnemonic is, she turned 45 at no ovary and a narrow aorta. So I used this mnemonic. She turned 45. So turned, she, that itself is a clue. She, this is a female phenotype. She turned, that turn will make you to think about Turner syndrome. She turned 45. So 45 makes you think about 45X0. All right, that's a high yield cytogenetic detail. And then no ovaries. So there is a streak ovaries. And the narrow aorta, that is for coarctation of aorta. So this is a very good mnemonic. This is what I used for my exam. So I highly recommend using this mnemonic for your exam too. So incorrect answers: trisomy 21, Down syndrome. Down syndrome results from an extra copy of chromosome 21. Presents with intellectual disability, characteristic facial features, hypertonia, congenital heart defects, most commonly atrioventricular septal defect. Although endocrine abnormalities may occur, does not cause streak ovaries. There are no streak ovaries in Down syndrome. And hypergonadotropic hypogonadism with primary amenorrhea. Short stature and cardiac findings in this question are better explained by Turner syndrome. Yes, like maybe some cardiac abnormalities are there in Down syndrome, but when in examinations, they don't confuse you too much. They will give you characteristic features. All right, then what about 47XXY? That is Klinefelter syndrome. Klinefelter syndrome affects males and is characterized by testicular atrophy, infertility, gynecomastia, tall stature, elevated FSH/LH with increased estrogen levels. It is not seen in phenotypic females and does not present with streak ovaries or coarctation of aorta. All right, Klinefelter syndrome affects males. Then there is Robertsonian translocation involving chromosome 21. Robertsonian translocations involving chromosome 21 are common genetic mechanisms of familial Down syndrome. This results in features of trisomy 21, not monosomy X. It does not produce primary amenorrhea with streak ovaries. So super formula is about going to the right answer within a few seconds. Already, whenever you say there is a female patient with webbed neck, short stature, 44X0, stick ovaries, and coarctation of the aorta. They're talking about Turner syndrome. All right. So it is full of high yield content. Okay, remember that. So super point here is Turner syndrome is characterized by stick ovaries, short stature, cardiac anomalies such as coarctation of aorta, while Down syndrome, trisomy 21 causes intellectual disability and congenital heart disease. Klinefelter syndrome causes testicular atrophy, infertility, and gynecomastia in males. All right, folks. So I want to stop there for today because our time is up. And I will see you in the next episode. Please visit us at superpoints.ai for more resources as you prepare for your examination. All right, I will see you in the next episode.